Welcome to Accessible, where we open the door to the people and ideas shaping the disability community. I'm George Gatto.
And I'm Amelia Reigard.
On Accessible, we talk with leaders, advocates, researchers, and individuals with lived experience to explore the issues shaping the disability field.
Accessible is produced in partnership with the Missouri Leadership Education in Neurodevelopmental Disabilities, or LEND, and the Missouri University Center for Excellence in Developmental Disabilities, or UCED for short.
And whether you work in the field, are connected personally to disability, or simply want to better understand how systems can support people with disabilities, Accessible opens the door to conversations that matter. I was sorry to miss Sheila because, I just think she's so interesting. Like her background starting in the St. Louis County Jail and recognizing how many people who were coming through the jail system had disabilities, developmental disabilities, or some sort of behavioral health thing, diagnosis. I don't know if they actually had a diagnosis, but it was probably, anyway, I thought that was super interesting. And I think it was clear from her conversation that brings a sort of a refreshing, or at least a different perspective than what we're maybe used to.
Mm-hmm. Yeah, I think absolutely. It was interesting to see, the role that she fills now as the director for the Division of DD for the entire state, having so much direct practice experience in all these different service systems, right, that are directly impacting Missourians, that she gets to bring that perspective into what she does. And that is, one of the main reasons for that pilot project that she ended up talking about at the end of towards the end of our conversation is these really great pilot projects where they're exploring how to better serve people with dual diagnoses of maybe a behavioral or a mental health diagnosis and a developmental disability. And so it'll be cool to see what comes of kind of the innovative approach she takes to her role.
Yeah, absolutely.
Yeah. And she also just kind of, one of the reasons why we wanted to reach out to her is because, the Medicaid changes are a hot topic. It's something that, even without making that the theme of a lot of the episodes this season, it has been something that's come up in almost every conversation. And so we kind of wanted to talk to the director of DD, somebody who's keenly aware of all of that, all of those changes, and kind of get the scoop on what people actually need to know and how they're really just getting proactive. We have some time before those changes go into effect. Mm-hmm. So what things are they doing to sort of mitigate, confusion or gaps in services or coverage for people with disabilities, and just get information out there.
Yeah. Absolutely. Well, I just really enjoyed the conversation, and I was sorry that I couldn't be a part of it, but I am sure that our listeners are going to enjoy it.
It was great to have producer Catherine as a co-host.
Yes, right. They let me have a live mic this time.
She did good. She did great.
All right. Thanks, guys.
Yeah, thank you.
All right. Enjoy
the podcast.
Well, welcome back to Accessible. This is Amelia Reigard. I am almost flying solo today. George, unfortunately, could not be here for this recording, but we have the treat of producer Catherine stepping in.
Hi.
But we also have the pleasure of having Sheila Wunning on with us today. Sheila is the director of the Division of Developmental Disabilities within Missouri's Department of Mental Health, and she's here to talk to us a little bit today about the division and some current events going on. Sheila, welcome. Thanks for joining us.
Thank you for having me.
Yeah, our pleasure. We're glad you came along. So I think it would be great, Sheila, if you could start a little bit by telling us about your role as the director of the Division of Developmental Disabilities and how your office supports people with developmental disabilities across the state.
Well, I think maybe I'll start out by just talking a little bit about the Division of Developmental Disabilities. So, as you mentioned, we are a division of the Missouri Department of Mental Health. So, the Department of Mental Health is one of 16 state agencies, executive agencies in the state of Missouri. And so the department actually has three divisions. We have divisions. One is a smaller administration division, and then we have two larger service divisions. So we have the Division of Behavioral Health and then the Division of Developmental Disabilities. So the Division of DD has an operating budget of about $2.2 billion annually, and we have about 3,100 employees that work for the division. And we operate really primarily as a funder, but we're also a provider of service. And we serve statewide about 44,000 individuals through the division. So, just kind of thinking about the types of services that are available. So, in Missouri, we have your Missouri Health Net is our Medicaid program. And so that state plan Medicaid allows individuals with IDD to receive targeted case management services. And so the state actually provides some support coordination, and then we also contract with other providers to provide the targeted case management service throughout the state. And then we also have 4 agreements with the Center for Medicaid and Medicare Services to fund services, direct services through Medicaid waiver programs. So the types of services that we provide really vary anywhere from in-home services, so things like maybe personal assistance or independent skill development. We have a variety of employment services that help people find and keep employment in the community, on up to services like day habilitation and even residential services. All of those services are provided in the community. So, people sometimes when they think about residential services for people with intellectual and developmental disabilities, they picture institutional settings. And I'll talk a little bit about that. But almost everyone who receives residential services in the state of Missouri receives those services in the community. So they're living in their own apartments, in their own homes, a lot of time with roommates, and they have staff that comes into them, or they may live in the home with staff. So that's kind of a little bit what our community services look like. And we serve about 17,000 people in those Medicaid waiver programs. The state, as I mentioned, is also a provider of service. So we do continue to operate some of those facilities that I mentioned. These days, we have less than 200 individuals in long term residential services in our facilities. We do have 4 habilitation centers with 6 campuses across the state. We do these days, we don't do new long-term admissions to our state facilities, but we do a lot of crisis stabilization services to try to help people that may be experiencing some difficulty in their community placements. It's kind of we're expanding if we are, as that population is getting smaller in our long-term census, we're expanding those services that help support the community.
Okay. That's really interesting. So when you talk about the crisis stabilization and not taking on any new long-term residents in those facilities, you're really talking about transitioning to continue to keep people in the community as much as possible. So if they need, the crisis stabilization is a short-term effort in order to get people back on their feet so they can remain in the community.
Yes, exactly. We have had we have made a lot of changes to try to help us work with that population that sometimes have much higher behavioral support needs. There, for a period of probably 3 to 4 years, we were averaging 40 to 50 individuals who were boarding in acute care hospitals. So they had developmental disabilities. They may have been presenting with some sort of a psychiatric emergency when they went to the hospital. Sometimes a provider may have just not been able to support the person and they just took them to the hospital. But then the provider maybe wouldn't take them back, or they didn't already have a provider and they just would just kind of get stuck in the hospital. And sometimes people were in the hospital for more than a year and they didn't have any reason to be there. So we've worked very hard to really tackle that issue. A lot of those individuals have dual diagnoses, so they do have a developmental disability, but they have a co-occurring behavioral health diagnosis. And so we've really put a lot of effort into improving the capacity of our community providers to support those individuals that have the dual diagnosis and some higher behavior support needs. We have also developed a new program in conjunction with our Division of Behavioral Health called the HEART program to serve individuals with really acute psychiatric needs that have a dual diagnosis. But we've also really expanded our ability to provide crisis stabilization in those state facilities. So over about a 18-month period, we expanded that capacity by about 55%. So very happy to report that today we average somewhere in the neighborhood of 10 individuals at any given time that may be boarding in a hospital, but almost always everyone on that list has a plan for discharge. So we very actively on a weekly basis are working um, to look at those individuals and make sure that we're looking at all of the resources that we have and getting those individuals connected with the right resource so they don't end up staying in the hospital for extended periods of time.
Yeah. It's interesting, Sheila. I feel like that conversation has come up in some of the work that I've done here, with the Institute has been around health and healthy living and healthcare access for people with IDD. And it seems like over the years, there's always been that conversation around individuals who both have that behavioral health need and also might have IDD, and sort of the unique barriers that they might experience, right, to thriving in the community, and or the even on the system side of things, right, the lack of knowledge maybe of providers about how to best support those individuals. It's just something that we've seen a lot over the years. It sounds like there's maybe been a really concerted effort to bring that education piece, especially on the provider side, to help them figure out. Is it common that even that there's not awareness that there's dual diagnosis, right? Because not everyone who has maybe developmental disability is already receiving services or connected to like kind of the formal system, and vice versa, right? Like somebody might have a developmental disability and a behavioral health, but it was overlooked maybe, or not diagnosed because it was ascribed to maybe like a disability specific. Um, I don't want to say behavior, but I don't know if you know what I'm getting at there, but
So I do think that still probably happens. I, so I'm going to talk a little bit about one of our really exciting newer programs. Again, we're really trying to keep people in the community and we're trying to be more proactive so they don't hit the hospital. So part of that, like I mentioned, is really working on just improving the capacity of our community providers on both sides of the house, our DD providers and our behavioral health. But we have started a program. We piloted it in St. Louis. Actually, in a prior position, I worked with our chief medical director to develop a program. We call it DD Psychiatric Stabilization Service, or DDPSS. And so we went live with the program in January of 2024. So what we did is we hired a psychiatric nurse practitioner to work directly with Dr. Angelin Stanislaus. He's our chief medical director. to provide in-home psychiatric stabilization to individuals with dual diagnoses. And we took a little different approach. Most of the time, we rely on referrals for programs, which is great. But, we have just literally thousands of support coordinators throughout the state. Like I mentioned, we have contracted providers, we have state support coordinators, and sometimes they may not recognize when someone does have a dual diagnosis, or someone may not call them until the crisis is such that the provider's going to give notice or they've already given notice. And so we developed some reports that we pull data from our incident management system, which that can give us information about uh, everything from emergency room visits to law enforcement involvement. But we also pull claims data so we can look at things like a lot of recent medication changes, psychotropic medication changes, our number of medications. So we just kind of compiled a report that helps us identify people before they've actually hit that point where the provider's given notice. And then that psychiatric nurse practitioner goes in, we make contact, make sure they need the support and want the support, but then we provide that service. And we have had a tremendous amount of success with that. We've also been able, when we have maybe someone who provider has given notice, we've been able to work with that person, and then the provider ends up just retracting that notice. So we originally started that just on the eastern side of the state, kind of in the St. Louis area, because that's where our chief medical director was located, and just kind of that's our hub of service. But it went so well that we had asked for a new decision item. And so for this current fiscal year, FY26, we had funding to add another psychiatric nurse practitioner and part-time psychiatrist on the western side of the state. So we're just getting that up and rolling. And on that one, we're doing a little pilot. We're adding some other interdisciplinary team members. So we're adding some OT and PT and ST to kind of round that team out, and a behavior analyst. And they won't all respond. It will depend upon the needs of the person. So very excited about that and really happy with the results we're seeing so far.
Oh, that's so awesome. I feel like that will make like a huge difference. I mean, even it's like you're interacting with all different providers. They're not all talking to each other. You got your medication changed, but didn't know that it could affect you. And I don't know, I just feel like that having someone sort of like checking all of the ways that someone could have been like something could be affecting them and getting all of their ducks in a row. I feel like having that oversight is gonna be just life changing for so many people.
And you're spot on with, I think one of the most valuable aspects is that that nurse practitioner is actually seeing that individual in their home. They're watching the interactions the person has with staff. And they do, certainly a lot of what they do is related to medication, but sometimes it's really changes in the environment and changes in how people interact. And I think what we know, I wouldn't say it's what we've learned. I think, I've always kind of believed this. When you have people with really complex needs, you have people that a lot of times with a dual diagnosis, and a lot of times really a trauma history too, that's really, really impacting their support needs as well. You just need that team person. Our standard, this is our plan. The case manager goes out, they do the plan meeting, we put the supports in place. It's not necessarily enough for some people with really complex needs, so that having that psychiatric nurse practitioner to kind of head that team up really has made a difference. So
Hmm.
very exciting.
Yeah. Yeah. And being in the home and being like one on one or like just being in that environment, I feel like you learn so much more than you would just from like a telehealth conversation. Um, yeah.
Yeah. That's an exciting program and pilot. And so I assume if as you um figure out how these things work in these on the eastern St. Louis area and the western side of the state, I mean, would it be a program that might expand? And also, I guess, what does that look like in more rural parts of the state?
Yeah, and I think that would be in fact, Dr. Sanis also said she'd like to add one more, and we hope that we might be able to cover most of the state with a third. So we'll kind of monitor this. We are actually working with our state operated programs. We do have uh, some facility. We have a rehabilitation center, an ICF IID facility on the western side of the state in the Higginsville area. And then we also have a really unique crisis program called Optimistic Beginnings that's in the Marshall area. So we're really pulling some of the other staff from those two programs, primarily from that Optimistic Beginnings program. So I think we'll see what we learn from this, and then look at how we can expand. One of the other great opportunities about this too is that sometimes if the person has a psychiatrist and that they're happy with the psychiatrist, our psychiatric nurse practitioner may just provide consultation. But much of the time, they do actually take over the psychiatric care for the individual, or maybe the person didn't have, stable psychiatric services, so they may, maybe initial. And then when that person is stable and ready to transition to psychiatric services in the community, then that psychiatric nurse practitioner works with the team that will be providing service, and then continues to monitor and provide follow-up. And I think that can be key, because I think we talked about this a little bit earlier. But there is a lot of I would say it's kind of fear. I think a lot of times some of our CCBHOs that provide psychiatric services in the community are a little bit nervous about working with people who have dual diagnoses, especially if they have a fairly significant developmental disability. And so I think this is also a wonderful opportunity for our chief medical director to kind of identify areas where maybe we need to provide some more support, and for their providers actually to work directly with our psychiatric nurse practitioner and Dr. Stanislaus in those transitions. And it gives them it's a good training opportunity.
Um, Sheila, I'm wondering how this program, this pilot program, and sort of that dual diagnosis piece relates to some of your background and how you got into the field of DD. You said you started working in a county jail. Would you tell us a little bit about kind of your start into this field and what you observed way back when, and how this program sort of ties? 'Cause I feel like there's a really strong through line here, which is really cool.
Yeah. Yeah. I do. I feel like I've had just a a wonderful career path. I have been very fortunate throughout my career to kind of it's just I feel like the river of life has led me from place to place, and I've always actually been very fortunate to be very connected with what I was doing. But I did not probably take the traditional path, getting into the field of developmental disabilities. Most people, when you ask them how they got into the field, they talk about, maybe a family member with a developmental disability, or someone that they knew in school or in their neighborhood. And for me, actually, I was very interested in the criminal justice system, and I was majoring in criminology and criminal justice. I really thought I would go on and do research in sociology, but made some different life decisions. And so when I graduated with my degree, I had to go to work, and so I started my career as a correctional officer at the St. Louis County Jail. So I worked in we had a minimum security facility, and I had spent some time there. And then most of my career, I worked in the maximum security male facility and then rotated into the female jail. And so while I was there, I was really struck with how many people that had developmental disabilities, sometimes significant developmental disabilities, and also mental illness and substance use disorders they would come in. A lot of times they weren't able to post bond, so they would sit in jail and then they'd go to court. A lot of times their charges really wouldn't be all that serious, but they just were in this loop. They'd go to court and then they'd be released. Sometimes, they didn't understand if there's a lot going on. You've just met the public defender. They give you a piece of paper and tell you you have 24 hours to go to the probation office to sign up for your probation. If you have a developmental disability, you may not understand what they're telling you. You know that if you say yes, you're going to go home, and that's what you want to do. Um, but what happens is that a lot of times people don't make that initial contact even. And then there are a lot of requirements. And so people, a lot of times, without ever committing another crime or getting new charges, end up they're not compliant with all of the requirements of probation, so then they end up with a warrant, they end up back in jail. Usually the first time they'll get back out on probation, and then maybe the next time maybe they started out with a suspended imposition of sentence, but then they'll get a suspended execution of sentence, so now they have a conviction on their record, and then maybe they'll end up going to prison and then back. And so it was just really heartbreaking, honestly. And I just felt like while I honestly enjoyed what I was doing in many respects, I was involved. We created a special needs unit for our new justice center that they were building, which is not new anymore, but I still think of it as the new justice center. But it's a lot of good opportunities, but I just wanted to do something more proactive. And so there was the small agency in St. Louis that's funded by some of the Senate Bill 40 boards. So they have now funding from St. Louis City, St. Louis County, and St. Charles County, and called Options for Justice. And so they worked with people who were charged with felonies. Sometimes they might be pretrial, sometimes they could be out on probation or coming back out from prison on parole, who had developmental disabilities, and really just working to put supports in place to really help them stay in the community and not reoffend and meet all of the requirements of their supervision. So sometimes that meant going to court and talking with the judge about community supports that would be available if the judge considered probation, or sometimes it was really working with that individual while they were out on supervision. So that's how I started my career. And then I had an opportunity to actually go to work for the St. Louis office for DD Resources. So that's the St. Louis City Senate Bill 40 board. Soon after they started doing that targeted case management service by contract with the state. So I spent about 11 years there at DD Resources. So I worked truly as a support coordinator, and then as a mentor, and then have a supervisor. And then we actually had a really cool program. So DD Resources at the time was located right on the edge of downtown, kind of downtown, midtown section. And so the city board had applied for funding from HUD to open a safe haven project. So we had a drop-in center for people who were experiencing homelessness, so they could come in and take showers, do laundry, access the internet, so that they needed to apply for jobs or just create an email account. And then we really opened that primarily to find people who were experiencing homelessness that also had developmental disabilities, and then put those folks connected to long-term supports. And so we had a transitional housing program. So I had an opportunity to run that program for a while. I was very passionate about really, again, people with dual diagnoses and people who um, just really aren't getting the supports that they need. So it's a great experience. Sad many times, and but also just really when you were successful at getting someone connected with supports and seeing someone kind of go through from coming in the door, maybe they're sleeping outside to going through that transitional housing and then ultimately in permanent housing. And that certainly doesn't happen for everybody. But when you see, just that one person, what it's made. So that was very rewarding. And then I worked as the director of targeted case management there at the board for the last couple of years before I joined the state. So here I've had an opportunity to do a lot of things here too. I actually started with the state as a superintendent, one of those ICF IID facilities. So I had two locations in the St. Louis area, and we were just really getting our crisis program going at that point in time. And then from there, I moved into an assistant division director role, working with our St. Louis regional offices and also the case management statewide. And actually, May of last year, I had an opportunity to move into the director role, and it's just kind of cool. I've been in the field about 30 years, and I've had experience kind of on the provider side and then our community operations and our state operations. And so it's just kind of exciting to get to bring all of that experience together. And it is certainly a challenging time when we think about budget. We're facing certainly challenges, but it is an exciting time. We've talked a lot about, services for people with dual diagnoses. And ever since I started at Options for Justice in 1996, I have spent time being on committees and we would, for how do we improve services for people with dual diagnoses? And we would talk about what the barriers were, and we would decide, oh, we use the same words to mean different things. And we have acronyms and it's hard to know who to refer. And we'd come up with a list of acronym definitions, and we would come up with like phone lists, and we would come up with directories, and we would do all these things. And then I'd turn around and someone would want me to be on a committee, and we'd start over and we'd identify the barriers and we'd come up with the acronym list. And so I really have to say that I feel like we're finally making progress. Like our two divisions are working very closely. We are truly one DMH now. Director Hoon is incredibly. I remember when she became the division director, and I went to a meeting about what do we do about the people with dual diagnoses, and she's the first person that I ever heard say, it's not my money, it's not the division's money, it's not behavioral health money, it's not DD's money, it is Missouri's money, and it's to provide services, and we have to work together. And so she, as the department director, is really committed to that. And I think that we've just seen a lot of progress in how we work together. And we certainly still have a lot of room to grow, a lot of areas where we still need to work. But it's just, I feel like we're at a time where we're continuing to take steps forward. I don't feel like we're taking a step back for every two steps forward, even. I think we're just really moving forward. So it's an exciting time.
That's cool. It's cool to hear about your trajectory in the field and also to hear about just the viewpoints of, for you being the director of Division of DD and for Val, and just her vision for the whole Department of Mental Health. It seems like there's some good people in place to really take Missouri forward. I think I just saw recently that Val was appointed to some national advisory group around
Yeah,
health.
it's a national task force on improving healthcare outcomes.
It's a pretty competitive, I heard, application process. So for Val to be selected and for Missouri to be one of those few represented on there is pretty cool.
Yeah.
So yeah. Just you said so many cool things, Sheila, in your trajectory and all the things you've done in your job. It's going back to those pilot programs you had talked about at and your vast experience, it seems like what I'm just noting about it is the importance of like the interdisciplinary team, right? And to have these major systems that are interacting with citizens, right, at different levels, whether it's the criminal justice system or behavioral health systems or the disability service systems, to be talking with one another, to be working together to solve these community issues, right? And to create some sort of cohesion between these systems because it seems like yeah, what you're describing that these new pilot programs are doing is really keeping people from falling through the cracks, right? And having the providers and the systems talk to each other and work together and come up with solutions that were really supporting people um, in a holistic way, which is exciting, I think, to see what the impact of that will be like long term.
Yeah, I agree. And I think probably the biggest challenge is taking it from that where it is a pilot or it's something that's working well here and just really expanding it to where it's the rule, not the exception, that the systems together. And I think you make a great point about working with the criminal justice system. And we certainly are, I think, taking some big strides in that area too, but certainly there are a lot of opportunities, even just how we work together with other state agencies too. I think it's something that we're working, we're working closely with our health and senior services and social service agencies on No Wrong Door, which is another initiative that UMKC is involved with. But just trying to really streamline processes and make it easier for individuals that need help to get the help that they need rather than having to figure out what help they need and then how to go about getting it. So,
Yeah. I was kind of thinking about like as you're talking, it's like there's like 2% or something of people in Missouri have a developmental disability, but not all of those people are getting services. So there's amount of people that are falling through the cracks. They're probably interacting with some system. It's just not maybe a system that's giving them supports or healthcare or whatever. It might be jail or something like that. So just trying to figure out if we have them, whether they are interacting with police, they're not falling through the cracks in that moment. We have them in front of us. So how can we take advantage of that interaction to leverage that for an outcome that doesn't end up in a loop like what you're talking about?
yeah.
I mean, that sounds so simple. Like it's almost like it's just so you gave them a paper and said they needed to come back the next day to a different office. But they're also in a completely weird environment, probably experiencing some level of trauma, which we know that affects your executive functioning, your ability to focus. And you're also like maybe dealing with some level of instability where you might even not even have like, what are you going to do with that piece of paper if you live on the street? You might just lose
Right.
it. So there's
Right.
so many things that can happen, even in that little example that you just
Mhm.
talked about.
Yeah.
And I just feel like it's so valuable that you have that understanding. It brings like a level of like compassion and understanding to some of those things where some people might just be like, well, why can't they just show up? Like, they broke the law, they need to show up. And it's like, well, it's so much more complicated than that,
So much more complicated than that.
Yeah,
Even if you don't have a disability, it's so much more
totally.
complicated than that. So many people who are in that situation don't have access to transportation and have income. And so just logistically getting somewhere is, a monumental task. And I think if you haven't either been in that situation or really worked with people in that situation, you just don't realize how many people there are that are honestly just so impacted by poverty that their ability to navigate systems, whether it's the criminal justice system or, you know, healthcare systems, are just really impacted by that. Just it can be a big barrier to access.
Well, I'm excited to see how these pilot programs develop and kind of the outcomes that they produce for Missouri over the coming years. I wanted to talk about one other big thing that we wanted to touch on base with you on, Sheila, before our time is up for today. And so I wanted to talk a little bit about Medicaid. You went over some of the services and programs that the division has and mentioned, Medicaid waivers and programs with CMS, right? And so there's a lot of discussion at the federal level about changes with Medicaid. And so wondering from a state perspective, if you could talk a little bit about um, what you're seeing, what you're preparing for, what you want maybe Missourians or the public to know about proposed changes and how it might impact them. Um, you could start anywhere you want with that, Sheila, I guess.
Well, I'll start with the good news. So, the good news is that most of the individuals that the division serves won't be directly impacted by the changes to Medicaid through the One Big Beautiful Bill Act. So, I think that the two things that people are most concerned about really are the work requirements associated with maintaining Medicaid, and then also the more frequent re-verification process. So the redetermination process, which currently is an annual process that will be moving to a biannual process. So there are certain Medicaid eligibility codes that will be exempted from those requirements. So anyone who is eligible for one of our Medicaid waivers has a Medicaid eligibility code that is exempted from those requirements. Now, we do serve some people in that state plan targeted case management service that I talked about who may be eligible for Mo Health Net through that adult expansion group, so through the Medicaid expansion. Now, those individuals would be subject to the work requirements and the more frequent redeterminations. Many of those individuals would probably be eligible for disability-based Medicaid. It may just be how they presented when they applied, resulted in them being opened up under that adult expansion category. So one of the things that we are doing now to prepare is really coming up with some just routine reports that we run to identify those individuals and then developing a process to get that out to our targeted case management providers so that they can work with those individuals to explore whether or not they're eligible under a disability based code. One of the other changes that we are aware of as well is that, now when someone applies for Medicaid, they can request prior quarter coverage. And so then that takes their coverage back either to the point of application or, you know, 90 days prior. So from approval. And so that is sometimes we have people that have disruptions during their Medicaid coverage. And so we have then that 90-day period for some groups, like the expansion group, that will be now a 30-day period. And for people with disability based codes, it will be a 60-day. So we are also working on some processes to help us catch those disruptions to coverage more quickly so that we can be responsive and assist individuals in resolving those issues before it becomes a problem. Now, I think from, I guess, taking a step back there, the larger, we do know that some of the changes, for example, to that provider tax will result in, and again, so our ICF IID facilities are subject to that provider tax, and there is no change. Those facilities were exempted from that, but we are going to see a reduction in federal dollars coming into the state as a result of that. It's too early to tell how the system will respond to that, but it's definitely
Yeah.
something to be aware of.
Yeah. I think that with all the proposed changes and all the discourse about it, that there's, people, they have a lot of questions. There's some misunderstandings about what's being proposed with changes, even you explaining some of what the division's doing to sort of catch where there might be, people who are eligible, like you said, to be covered under that exemption, and kind of help support some of those changes. But are there common misconceptions about the Medicaid changes that you guys are encountering and that you guys are responding to?
Yeah, so I would say those first two things that I talked about, the work requirements and then those biannual redeterminations,
Yeah.
are a lot of people, I think, don't realize that um, because their mental health net coverage is disability based, their eligibility code is disability based, that they're exempted from those requirements. So
Yeah.
we've spent a lot of time. I know I've talked really in a lot of places about that. I've talked to our provider organizations. I've talked with our DD Council, our Missouri DD Council about that, and I've talked with our Quality Advisory Council just to kind of help people understand that. I think another thing that people are really worried about is that even though they are exempt from those requirements, that we know that this will create a lot more work for the Department of Social Services and doing these more frequent redeterminations and then tracking compliance with the work requirements. And I know that that's something that there's a lot of fear about. And we certainly are looking at ways to just improve, just in general, how we're tracking eligibility and how we're being proactive in supporting people with the redetermination process. I do think that, and I can't speak for social services, but my understanding is that they are really working towards doing, I think the process, it's an ex parte process, but basically where they can, instead of requesting information from individuals for that redetermination process, using that electronic information that they already have access to do those redeterminations to kind of just make that process go a bit more smoothly. So I'm hopeful that we will see a lot of efforts around that. And I know they're really trying to gear up for it. But that is certainly something that people are worried about.
Yeah.
I mean, going from what we were talking about, all of the barriers and all of the things that can come up, especially if people have lack of access or experiencing poverty, all of these things, and then to talk about all of these changes to Medicaid that are going to make a lot of things harder for a lot of people. It's just kind of like, I don't know, I feel a little bit like, oh, no, like, no, not that. But I'm glad that y'all are thinking like proactively and creatively, and luckily it's like a little bit of time to sort of anticipate some of the things that are gonna be an issue and try to be on top of it. Um, I don't know. So I feel comforted that y'all are have that mindset, especially like working collaboratively and kind of getting ahead of some of those things. But I imagine it's a little bit still overwhelming to you can't anticipate everything.
It is. And I think
Yeah.
people are also very concerned. We know that the state of Missouri is expecting a significant decline in revenue over the next few years. We're looking at about a $2 billion, uh, shortfall in revenue. And so we know that that will impact all state agencies. And we also know that the cost of care, so when I look like over the last 5 years, I had this graph, but if I could show you, but I'll use my hand. You look at the cost of care, so the cost of funding those services through the Medicaid waivers that I talked about, that has more than doubled in a 5-year time period. And, I mentioned we have a $2.2 billion operating budget. Much of that really does go directly to funding those services through the Medicaid waivers. And we're, seeing both increases in the number of individuals presenting for service and then also increases in acuity. So people need more services and more of the services that they receive. So each year, we are requesting utilization increases based on that. And we know that's just not sustainable. Even if we weren't expecting to have less revenue coming into the state, we know that we can't see those costs continue to increase like they are. So that is a really big focus for the division right now. We have several work groups made up of people from the division, but also people from our service organization. So Starling is the association that represents many of our service providers. And then Matt DVS, the Missouri Association of County Developmental Disability Service Boards, represents many of our County Senate Bill 40 boards. So we have representatives from both of those organizations, as well as self advocates on some sustainability work groups that have different focus areas. So one of the things is Medicaid. So, I've talked about some of the really just supports we're putting in place to try to be proactive and responsive to eligibility changes. That's kind of a low hanging fruit. Um, but we also have work groups looking at things like our residential services or our personal assistance services, and just looking at how um, we can make sure that we are making good decisions consistently about who's getting, we want people to get the right support at the right level at the right time. Director Hoon always talks about, you know, ideally what we want is to be able to have something for everyone instead of everything for some, you know.
Mm.
So that's really our goal with those work groups, to try to just be a little innovative where we can, and also make hard decisions where we have to just make sure that our services are sustainable.
It's interesting. I think that interdisciplinary conversation we had before, I assume actually, I shouldn't say assume, I think through, cost benefit analysis type studies we've seen in the research before, is that if we're talking about a shortfall in the budget for Missouri overall, that if these interdisciplinary and kind of innovative approaches to meeting people's needs, if we can lower, the cost going through the criminal justice system for somebody who just needs that crisis stabilization service to really then thrive in the community, and then they're not kind of going through that revolving door of the criminal justice system, you're in effect reducing a cost there. Same for that long-term sort of boarding in the hospitals, right? If people are getting the services they need to then be back in the community and back on the job, or doing those things, and then you're reducing costs in the budget elsewhere, right? So it feels
Right.
like an opportunity for that interdisciplinary team approach, the sort of the rising tide raises all boats kind of approach.
Yeah, definitely. And one of the things that Missouri has been working on for just the last few years is looking at value-based payments and trying to shift our system. Missouri is not a managed care state. We don't have managed care for our IDD services, but we do realize that there is some value in being able to pay for outcomes instead of just units of service. And so, that this could be a whole nother hour-long conversation. Uh,
We'll have you back next season, Sheila.
but, it is, I think it is a way to kind of do, just kind of, I'll give you an example that, we have looked at expanding the use of remote support. So we had some really cool options with regard to remote support and adaptive technology that can help people who've maybe always been dependent upon 24-hour staffing, but they don't necessarily need that level of support. It gives them an opportunity to be much more independent, have just a lot more control over their lives, and it saves money and saves staff. We also have had a workforce shortage and will continue to have a workforce shortage. When you just kind of look at the age demographics in the country, we know that that's going to continue to be a problem. So we do have a value-based payment that's kind of its cost sharing, savings sharing type of payment where our providers that participate in, so residential providers that work towards moving individuals to remote support. So maybe part of their time, instead of having staff, they have remote supports. There, we can track and show how much that has saved both in dollars and also in staff hours. So, and they get a payment, that incentive payment that they received as a portion of that cost savings associated.
Yeah.
Yeah.
We talk about that sometimes, like you don't always know the money you didn't waste, like if you were proactive, and it's harder to show that. So that's a cool thing where you can like see this is all the stuff that we saved by doing this kind of a different way.
Yeah, and there are ways. So we can use claims data. For instance, we call it the Health Coordination Service, the HAC service, in our waiver. So it started during COVID. We wanted to make sure that our individuals had access to health care when you couldn't really get out and maybe it wasn't safe to necessarily go to the ER or go to the doctor every time you had a minor illness. So we started working with a provider, Station MD, and to provide telehealth through the waivers. And so that is something that we're really, and so the Station MD specializes in providing healthcare to individuals with IDD. And so we're able to track cost avoidance there because they report to us how many contacts they had, and we measure diversions from urgent care or ERs. So they really run, it averages 92 to 94% most quarters of diversion from, seeking emergency care. So we can look at our claims data to see what the average cost of going to the ER is for specifically the people we serve here in Missouri, and then look at those, the number of visits that we've diverted and kind of calculate a cost avoidance. Again, it's not to our DD system, but it is to our overall, healthcare system in Missouri.
That's fascinating. I think it feels like it's been a bit of a theme for conversations we've had this season with leaders in Missouri. In particular, we're talking with the Assistant Commissioner of Special Education through the Department of Elementary and Secondary Education recently, and with you, that sort of with changes on the horizon to how we are doing things, or with federal reimbursements changing, or Missouri's, budget bottom line changing, those sorts of things that might be seen as challenges and barriers, but they're also really opportunities for innovation. They're opportunities to rethink what we're doing, how we're doing it, if we could do it better. And so I think it's been an interesting and cool theme to see unfolding, and to see people really rise to the occasion, which is exciting. I think I think things are very promising for people in Missouri because of that sort of framing and that leadership that we have. And anyways, I appreciate you, Sheila, sharing all the great work you guys are doing at the division, and also a bit about your personal journey. I feel like I've learned a lot. I've taken like 2 pages of notes, things that I'm like, this is very fascinating. Follow up later. And so, for those that are listening who would like to follow up with you, Sheila, or the division and get connected to knowing more about what's going on, is there a website or a Facebook or something that our viewers can connect to?
Yes, so we do. There is certainly the division does have a public website, and you can go where it is constantly a work in progress. We're always trying to make it better and more accessible. But we are also on social media. We have Facebook and Instagram and X, and I think I sent all of those links over to you. So you're more than welcome to share those. Those are all great ways to connect with the division. We also, I'll give a plug. So we are continuing to try to improve our communications. When I came on as the division director, we just had some really disheartening feedback that I very much understand, that a lot of the individuals that we serve and family members felt like the communications coming out from the division, like through our email blasts that came out very regularly, and even through our social media, a lot of times was really focused on providers. We were getting information to providers rather than really, thinking about the information that our individuals and families also want to have. And so we have a newer director of communications and engagement, Kelly Kimna, and the first thing she did, I challenged her, I'm like, okay, we need to fix this. We are here to serve individuals with developmental disabilities. And so that is our target audience. And so she did a survey, stakeholder survey, and has continued to do surveys. So we've made a lot of changes in how we're communicating. For instance, we've gone from, and this is all a great big plug for our DDD Weekly. So we used to send those email blasts out every time, like maybe there was a training opportunity, or maybe a change, coming in a requirement, or it could be, maybe there's an opportunity to, maybe it's a conference, just any kind of information that the division wanted to send out. They would send it in, and then our communications team would send out an email blast that went to everyone that was signed up. So you might, if you were signed up, you might get 10 in a week, some weeks. And that was a little overwhelming for people. So what we learned is that people really they preferred weekly communication. Overwhelmingly, people did prefer email versus all of the other things. So we decided to go with a weekly newsletter. But we also, there was a group of people that really were interested in having text options too. So we were able to sign up for a text service. So now we put all of those updates into one weekly newsletter, and then a notification goes out by email and text if you're signed up. And then you can go in and check out the newsletter and see kind of what's going on with the division. There are links to all of the training opportunities, and just kind of that they stay in there. Before, you'd have to save your email, but now, when we add a date for a training or whatever the opportunity is, there's just a running list over on the side of those upcoming dates. So people can go back and they're to register. So very excited about that, and continuing to do those communication surveys to see if people are happy with the changes, and then trying to tweak that as we go along.
Perfect. We'll be signing up too. Sheila, it's been a pleasure. Thank you again for agreeing to do this. It's been great to hear from you.
Well, thank you for having me. It's been a lot of fun.
Thank you for listening to this episode of Accessible. Accessible is hosted and produced by George Gatto, Amelia Reigard, and Catherine Toller from the University of Missouri Kansas City Institute for Human Development, which is the home of the Missouri USED. Accessible is a joint project between the Missouri USED and the Missouri LEND program, which is funded by the Health Resources and Services Administration of the U.S. Department of Health and Human Services through grant number T73MC00022.
Episodes of Accessible are released every 2 weeks and can be found wherever you subscribe to your podcast. Join us next time to hear more insights and ideas from leaders in the disability world.